My name is Dr. Wayne Alpenstone. I'm a chiropractor and a functional neurology practitioner.
So today we're going to be talking about the pain-producing structures of the spine. The main things we see in the office that is producing the pain. So the what's of the pain, what is giving you the pain. As chiropractors though, we are very interested in the whys, the roots of the problem. That's where we can make changes. Of course, we've got to address the problems of the pain itself and the structures that's producing the pain, but in the long run, as chiropractors, we are a lot more interested in the why. Today, however, we're going to be reviewing the basic anatomy, the main things we see in the office, and the basics about how we address those. Now, let's get started with the basic structure of the spine. You'll see the little picture I've put up for you. On the left side of that, you'll see these big, bony, square-like blocks. These we call the vertebral bodies. They are big and square because they absorb most of the pressure from the spine when we walk or move against gravity in our daily lives. So they're generally quite resistant to stress and load, and they are main structural holding elements of the spine. Below that, in between them, you will see these gel-like substances. They are cartilaginous on the outside, meaning the outside bits is like gristly cartilage, and in the middle we have like a gel-like substance. We call these the intervertebral discs, the very infamous intervertebral discs. Just behind this is a long tube that runs encased in these little bony structures, and in between them, you'll see these holes where our nerves exit. These are our spinal nerves that exit from our spinal cord, which runs in this tube. And the spinal cord is really an extension of the brain. And they kick out these nerves, which gives information to and from the rest of our body. Behind that is two sets of joints, what we call the facet joints, two very important structures, and these spiky bits that stick out from them. Now, these bits are so spiky because muscles attach to these areas that allow the spine to move. They move our spine and they brace us and they make sure that we're upright against gravity. Now, let's talk about the bony structures first. Most often, we don't see a lot of fractures in our office or disruptions of these bony bits. We only really see them in people that is getting a little bit older, mostly in postmenopausal women that is particularly frail. And what happens in them is they develop a condition where the bone starts thinning and becoming a little bit more fragile. And this means that otherwise normal movements can cause little cracks in that bone, or very common little compression fractures of that vertebral body. These, of course, are very painful and produce pain in all ranges of motion. Normally, just by watching somebody walk or come into the office, we can already see that something like this has happened. Most of the time, that area just has to heal, and it's our job to reduce swelling and inflammation and trying to promote as much healing as possible, and in the long run, to try and restore normal muscle function, to get normal motion back into that segment. We don't see a lot of these in young people because young people generally have quite firm and strong bony structures. You will only really see disruptions if the person's undergone severe trauma, either through sport or a car accident or a really heavy fall. And normally these people go to the hospital first, and we only see them once they've been diagnosed as a part of their rehabilitation and return to normal. Next, we have the intervertebral disc. And many of you have heard about the slip disc or the disc herniation. In reality, discs don't slip. What happens is we get disc bulges, the disc starts cracking, and the gel-like material starts pushing out and causes inflammation and irritation of structures around there, and especially around the nerve, which we'll speak about in a second. Or the disc can rupture completely, which of course can produce pain. The reality is the disc itself doesn't really have a lot of nerve supply. The disc itself is cartilaginous. It's a relatively inert substance and only has about 10% of nerve supply compared to the rest of the structures. And so lots of us actually have disc bulges. We just don't know we have them. Most people in their late 30s, 40s, 50s, if we image their spine, we will see some degree of bulging, which is quite normal. When it does become a problem is when this disc bulge pushes against ligaments, tendons at the back of the spine or directly compresses the nerve. So this is when we get that, when people talk about a pinched nerve. And the nerve will produce very characteristic radiating pain that normally follows a specific pattern. Now, the nerve supplies sensation, but it also supplies information for muscles to be able to work and signals for muscles to be able to switch on and off. So there's characteristic signs for when we've got a nerve compression. And not all pain radiating from a particular area. In actual fact, most pain that radiates from a particular zone is not necessarily a nerve entrapment. And the nerve entrapment will produce very specific patterns of pain. Now, behind this canal where the nerve exits, we have these two joints, these facet joints, and they are really important joints. The joints with the surrounding ligaments, tendons, its little joint capsule and muscles that sit around the area are very, very, very sensitive to pain. They have lots of nerve endings on them. And this means that most back pains that we get, even in cases of disc narrowing or degeneration, is as a result of inflammation, irritation, or a scratching of these joints. So what normally happens is there is an error in the way that we move. There is a slight mistiming in how muscles brace and move along these little joints, and this results in injury to the ligaments, to the tendons, or may cause the joints to, if you can imagine, scrape against each other, which will cause swelling and inflammation in that area. This means that every time you put pressure on your spine or move in a particular direction, it will produce exquisite pain in that area because it is so very highly supplied by nerve endings. Now, because there's so many structures around this facet joint, we call this a syndrome. And because it's the facet joint, we call it a facet joint syndrome. But in reality, what is happening is it's ligaments, muscles, and the joint that is all injured in this complex set of movements. If it's happened very rapidly, for example, your back is just gone while you were sweeping the floor or raking up leaves in the garden, we call this an acute injury. It means it's happened very quickly. Acute, it means it's developed over the last hour to 48 hours. It can be instant, but develops very rapidly over a 24-hour period. And so the acute management for these type of conditions is really orientated around reducing the swelling in that area, getting the muscles and the ligaments and tendons to heal, and then in the long term, facilitating a normal return to motion of that segment, and then strengthening the spine so that this is less likely to happen again in the future. Now, sometimes these areas don't resolve 100%. They resolve 50%, enough for us to get by, but the pain remains over a long period of time. And we call this a chronic facet syndrome or chronic lower back pain. It means it's pain that's been there for a longer period of time, generally sort of 6 weeks or more. In the chronic facet syndrome, changes are happening to the muscles, ligaments, and tendons, and they might take a little bit more time to correct. But what we've got to do is restore normal function, normal flexibility, try and work on any soft tissue disruption that's happened in that area, trying to facilitate healing of any scarring of that little zone, and then once again strengthen that area so that the person can return to normal as quickly as possible. It is important to remember that the brain learns pain. So if something has been there for a long period of time, these nerve fibers switch on very easily. And the brain and the nerve endings can be triggered a bit quicker to try and protect and limit damage to that area. So we want to address these things as quickly as possible. If an injury has happened, we want to get that person back to normal as quickly as possible. Now, if these conditions are present for a long period of time, what will happen is eventually we will get some degeneration that happens in the vertebral body, as well as the intervertebral discs, and as in the facet joints as well. They will just wear under the dysfunctional load and the movement errors that is happening there constantly. When this happens, we call this spondylosis. So spondylosis means that there is some disc degeneration as well as some facet joint degeneration that's probably happened as a result of a chronic facet dysfunction or chronic mechanical dysfunction in that area that has been persisting for a long period of time. These conditions are a little bit more tricky to manage. We can't really reverse that degeneration, but what we can do is we can slow it, and once again, we can strengthen that area and we can try and get the body to compensate around that damage as best as possible. Now, we do get something called referred pain, and this is a radiating type pain that happens distant to the site of injury and accounts for most of the things people call sciatica. Sciatica is a pain that we get down the back of the leg in the pattern of the sciatic nerve. We can also get nerve pains in the arm or shoulder that comes from the same structures in the neck, and they are not always pinched nerves. Most of the time, they are not pinched nerves. What happens is these joints, ligaments, and tendons get so irritated that they bombard this nerve that goes into that area with so much signal that it spreads the sensation to areas distant to the original site of injury. We often see this in the neck, where the neck really gets painful and the person will have pain over the shoulder blade area, or the person will have acute lower back pain, or they will have pain in the bum or the back of the hamstring. This is distinct to a pinched nerve because, like I described to you before, a pinched nerve is when we are causing a compression of the nerve, and this will disrupt the function of the nerve. Whereas in referred pain, the function of the nerve is intact, but the person is experiencing pain far away or radiating in a pattern distal to the site of the original injury. This can happen both in acute facet dysfunction or acute lower back pain, chronic lower back pain, or chronic facet dysfunction. It can happen with spondylosis as well. So just because you've got radiating pain that goes into the leg, the back of the leg and into the bum, does not necessarily mean that we have a pinched nerve. Now you understand the basic pain-producing structures of the spine. It's important to understand that these are the what's of the condition. What is resulting in the pain that you're experiencing, but it's not addressing the why. And the why is normally because we have small movement errors, little mistakes that our body makes against gravity. You can imagine this is a real complicated set of calculations that your body has to move. Every time you move, it has to brace and counter brace against gravity. And when the spine makes a little bit of error, what happens is we get some scratching of these joints and then the acute lower back pain. So we've just gone over the most common pain-producing structures of the spine. I hope this gives you an idea about what is causing your spinal pain. As chiropractors, we are invested in finding the whys of your spine so that we can deliver long-term positive change to your daily life. I look forward to seeing you again in our next educational video.